Hi, everyone. I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopedic Society for Sports Medicine annual meeting in Denver, Colorado.
The AOSSM meeting is a premier sports meeting conference each year, hosting over 3,500 attendees with hundreds of poster and paper presentations, exhibitors, and instructional course lectures. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 8 episodes, we're going to be exploring some cutting-edge sports medicine with these experts who are presenting at the AOSSM annual meeting. If you're looking for a trusted name in allograft transplantation and want to learn more about your allograft options, then look no further than JRF Ortho.
JRF Ortho is an innovative leader providing the widest array of pre-sutured tendons, including the only BTB pre-sutured tendon on the market. Plus, they are the first to offer OCA cores available in 10mm, 12mm, and 16mm sizes for small focal osteochondral defects.
JRF Ortho also prides itself on superior customer care, making your ordering process JRF Ortho easy. They are committed to accommodating your needs, usually delivering an osteochondral allograft around 30 days, all on your terms. So if you're tired of waiting weeks for a condyle or waiting on a back-ordered tendon, reach out to JRF Ortho to find out how you can get your allografts in a timely manner.
And the most amazing thing is that JRF Ortho aims to give you one less thing to think about, so you can just focus on what matters most, your patients.
So discover the only allograft company focused solely on sports medicine. Order your allografts today with JRF Ortho. Today's episode is going to focus on the management of patellar instability, including nonsurgical treatment, MPFL reconstruction techniques, and the addition of other procedures, including trochleoplasty and osteotomies. We're joined today by 2 outstanding guests.
Dr. Miho Tanaka is a professor of orthopedic surgery at Harvard Medical School and the director of the Women's Sports Medicine program at Mass General Brigham. She is also the head team physician for the New England Revolution and team physician for the Boston Red Sox, Boston Ballet, and Boston Glory.
Dr. Beth Shubin Stein is an orthopedic surgeon at the Hospital for Special Surgery and professor of orthopedic surgery at Weill Cornell Medical College. She is also the co-director of the Women's Sports Medicine Center at HSS and the director of the Patellofemoral Center at HSS.
So, without further ado, let's get to the field house.
Awesome.
Okay, whenever you're ready.
Right. So, Miho and Beth, thank you so much for taking the time to join us today for this special episode of the Sports Docs podcast, live from the AOSSM annual meeting in Denver, Colorado. Thank you again.
So excited to be here. Thanks for having us. Thanks for having us.
Yeah, thank you. Welcome. So today we're going to be speaking about your area of expertise, patella instability. But before we get into surgical management of these patients, we're going to start with initial evaluation. So Miho, what are you looking for in history and physical examination to help guide your treatment?
Yeah, so, I think it's important to recognize whether this is a first-time dislocation, whether they've had some in the past. Usually they come in and they say they've had this dislocation, but it's not really till you dig deeper until you recognize that they've had some, it started maybe when they were 12 or 13, even though they're now 25 coming into your office. And then looking at things like the other knee, family history, that can give you a sense of whether they might have some sort of risk factors for that. And then on examination, I think this is always tricky to try to determine how unstable a knee is, because a lot of people rely on actual dislocations, but I don't think we want to wait for the dislocation to happen. So using things like the glide test to see how far they translate, but of course comparing it to the other side, because some people naturally have laxity, and we really care about functional instability. So you want to know whether they have apprehension at the same time as well. And then looking at things like alignment and the rest of the knee exam is important.
Absolutely. So after that exam, obviously we're going to get imaging. So Beth, can you talk a little bit about what imaging you're ordering in terms of radiographs or advanced imaging to help kind of guide your treatment plan?
Yeah, great question. And I think, to Miho's point, just like the exam can tell us a lot and give us a lot of information that maybe the patient doesn't have or can't recollect. I think the imaging, we always start with plain radiographs. I think plain radiographs just give us a lot of information to start with. But for the most part, pretty much every patient who's complaining of instability, whether it's a subluxation or a dislocation in my practice, will get an MRI. When I started, CT was extremely common because the TTTG, which is the measurement tibial tubercle trochlear groove distance, had been described originally on a CT scan. It was before Philip Schottel actually described the difference between the TTTG on CAT scan versus MRI, and Diane Dom also then kind of vetted it so that we know now that there's about a 3 to 4 millimeter difference if you measure it on CT versus MRI, but this was the days before those studies, and we were getting CTs on a lot of really young patients. And so I started essentially extrapolating and just getting the TTTG from the MRI and using it in combination with lots of other factors like patella alto, trochlea dysplasia, but the MRI is pretty much probably my main way of assessing soft tissue, cartilage, translation. I think there's so many great measurements. One that I think doesn't get as much press as it should is the PT-LTR, which is the patella tendon to lateral trochlear ridge distance, which I think is such a great test because on MRI you can scroll through and without even measuring it, your eye can tell where that tendon is relative to the lateral trochlear groove. And David Deets loves to talk about vectors, and it really is a problem of vectors. And when you look at it, your eye can see it, and the patients can see it too.
Yeah, I think that's a great call out. What about rotational instability? Is that, are you strictly CT with that? Can you find that helpful on MRI as well, or how do you deal with that?
So that is something that we haven't figured out yet on MRI. So we do a rotational profile in patients where I see that I'm concerned. Usually it's in revision cases. I'm not really doing it in primaries unless there's a real reason to do it, because I think lots of people have some rotational malalignment, but you don't always need to correct it just because a number doesn't kind of fit in that normal range doesn't mean we have to actually do surgery on it. So I think for mostly it's really severe instability with a lot of dysplasias. When you look at them, you know something isn't quite right, or it's a revision setting. And then I am getting a CT, and it's a limited CT through the hip, through the knee, and through the ankle, so that we can get the rotational profile and assess femoral anteversion. And I think that is a really important part in those kind of very extreme instability cases.
Absolutely.
Yeah, and Miho, is that a similar workup?
Yeah, pretty
I
similar.
imagine.
Yeah, I think I also add standing x-rays hip to ankle. So looking at varus valgus, which I think is important. I do the CT, and then of course I do the dynamic CT, which I'm really a big fan of. For me, that's really important to look at a displacing supratrochlear prominence. So do they have, it's the radiographic equivalent of a jumping J sign, which we can see, and that helps me to determine, is there any chance that they might need some sort of trochleoplasty? Very, very uncommon in anybody's practice, but it does help me to look at that.
Yeah, absolutely.
So before we dive into surgical treatment, which we really want to get into because that's our passion, we want to talk a little bit about non-surgical treatment. So let's say first-time dislocation, not a lot of those gross, really super high risk factors. How are you treating patients, Beth, non-surgically? What are you doing in terms of immobilization, PT, things like that?
Well, you've picked one of my passionate
Oh,
areas.
good. Okay.
I'm actually running a prospective randomized controlled study right now, and have been for about 5 years, looking at randomized treatment to MPFL reconstruction versus non-op.
Okay.
Non-op being the standard of care. It still is. So unless somebody has a loose body or osteochondral fracture, the standard of care for a first-time dislocator, regardless of age, is non-operative. In the last 10 years, really since 2015, so a little less than 10 years, we have a lot more evolving literature that's showing us that the original literature that we kind of hung our hat on to make the non-op standard of care really wasn't risk stratified. It was one size fits all. And so whether you were 50 and slipped down the subway steps and dislocated for the first time, or whether you were 16 and playing lacrosse and had anatomic risk factors, you were treated the same. And that's actually still how we treat patients, and probably shouldn't be. But at this point, really what we have to do is evolve our treatment to match our prediction models. Now that we know that there are these high-risk dislocators who are under 25 with trochlear dysplasia and other anatomic risk factors, they have a much higher incidence. So first-time dislocator under 25 with trochlear dysplasia, 65 to 70% risk of recurrence. And so we're really trying to look at whether or not we should be changing our standard of care and maybe treating them a little more aggressively.
Yeah, it's like shoulder instability.
Yeah.
It's very different in a 16-year-old versus I dislocated my shoulder in my early 40s and I didn't do a thing.
Yes.
Exactly.
Exactly.
But specifically, because I don't know if you guys know, I was a physical therapist for 7 years, so I always want to get into the, the deets. So can you both talk a little bit about, back, when I was a PT, you would famously get the script, evaluate and treat. And that was it.
You must love that.
It's the best. So I'd love to hear a little bit. Do you get more, obviously with the protocol, I'm sure there's a lot of detail. But Miho, let's start with you. As far as how do you sort of talk to the therapist about what's important?
Yeah. So I think the first part is just getting out of the acute phase, getting the fusion to quiet down. I usually don't aspirate these patients. I think the things that help are anti-inflammatories, limiting certain, loaded movements, getting them into a brace so that they're stable while they're doing this. And then while they're doing that, I think you still want to make sure that they're activating their quad so that you're not digging yourself out of a hole once they've, quieted down. But I think the most important parts are, as they're starting to get their quad back, it's really important to get their hip, right, and the glutes, thinking about, what their feet are doing in terms of pronation. Are there other structural factors that might be adding to this? And then as they're getting that back, going pretty quickly into the functional stuff as well.
Yeah.
So it's not just straight leg raises, but really trying to get to the step downs eventually and watching how they progress during that.
I'm very similar. I'm not a big hematoma aspirator. I think usually you can get patients to quiet down on their own, and I think it works out very well, unless it's really a tense hematoma, in which case then I'll aspirate, but very rarely. I think the biggest thing that I see in my practice is they come in these immobilizers, and I am very quick to get them out. I would ban those. I actually think we should just automatically put them in some type of knee flexion brace with a little bit of a lateral buttress and then let them go so they get their range of motion back and their quad doesn't completely shut down. I agree completely with Miho. And then I think for me, eccentric quad control is the number one thing that I really want them to work on. And I'm a big fan of closed chain. I'm not an open chain fan. I think I love that there are great ways to strengthen and isolate the quad in open chain, and we live our life in open chain. But I find that open chain is extremely irritating to people's patellas, so I sort of stay away from it in terms of functional strengthening.
Yeah, agree. It is. It's provocative. A lot of people, it's, they're saying, oh, that's the only way I can contract or, activate or anything like that, but they just, it doesn't feel great.
I agree. So we talked a little bit about indications for surgery. So let's kind of dive right into surgical techniques. So before we talk about reconstruction, we do want to briefly talk about repair versus reconstruction. I know, but I have to bring it up, especially in the pediatric patients. There are still some pediatric orthopedic surgeons advocating for repair for first-time surgery for MPFL. So I can tell by the looks on your faces, not fans. But Miho, we'll start with you.
This is why you're here.
Yes.
Yeah.
What are your thoughts on repair versus reconstruction? Are you ever doing a repair or never?
I would say that if you looked at what we were doing maybe 5 years ago, before we got aggressive about treating these early, if somebody had an acute dislocation first time, had some osteochondral fracture or something like that, we would consider a repair instead of a reconstruction at that time. But we know from Andy Pennick's data that if you even with a repair, these failure rates are about 60 to 80%, especially if they have morphologic risk factors. And I think a lot of the data that is favorable for the repairs are at 2 years, but they fail after that.
Yeah.
And so I think that's the real issue. And so we've really moved away from doing any sort of repair, at least in my practice.
I stopped doing repairs a while ago. I think originally I had a very narrow indication, probably for the first 10 years. I had this very narrow indication that if you could get to somebody acutely and it was a first-time dislocation and you were going in for a loose body or an osteochondral fracture and there was a bony fragment or something, then you could actually attach it back to the bone, and it was very nice. It was you figured out where the tear was and you fixed it, whether it was on the sulcus side or whether it was on the patella side. I think our literature is now so much better. And in addition, in general, these patients have high risk factors. They don't start with good tissue. That's the problem that I think we're all kind of missing. It's not like a normal ACL that tears. It's an abnormal ligament to begin with. Most of them, if you examine their other side, they're sloppy anyway, and they just have some apprehension. So you're taking poor quality tissue that's had an injury and is now even worse and then trying to repair it. And in no world does that make sense to me.
Yeah. So everybody listening, stop doing repairs. You heard it here first. Awesome.
All right, so we'll move on to MPFL reconstruction. So we do want to discuss techniques, and this will be a question for both of you. And we want to get into a little bit about like graft choice, configuration, fixation, all those types of things. So Miho, go ahead if you want to work us down your algorithm.
Sure. So for me, I've actually transitioned almost entirely to the MQTFL. And I think the one thing that I would point out with this is that it's not high up on the quad. It's still really at that midpoint that we think about where the quad meets the patella. And so for this, I use Allograft. You know, I think Beth has a great reason for using Allograft, so I'll save that for her explanation. On the femoral side, I use an expanding anchor. So I like to use that because, you know, the interference screws, I think Andreas Kamal showed that you can actually over-tighten as you're putting the screw in. So it's a loop through the quad. I stitch that to the periosteum of the supremedial patella. I'm showing this technique today in the session, and then I have an expandable anchor in the femur.
Great.
Great.
I have a different technique. I actually love the idea of the MQTFL. I think the anatomic reasons behind it make a tremendous amount of sense. And I think in the first 10 years of doing MPFLs, we saw such horrific fractures of the patella and large tunnels that the MQTFL was a wonderful idea, not just anatomic, but also spared a lot of people a lot of complications. Yeah. I think at this point, in terms of knowing the risks, and the risks have gone way down, the newer studies that show the risks of fracture and the risk of complication after MPFL is much, much lower. I tend to like more rigid fixation. I do like bony fixation, so I use 2 anchors. I use it in the top, that juncture of the proximal third and the distal 2/3. I find the spot. Usually 8 to 10 millimeter bone bridge. There are 2.4 millimeter anchors, so they're very small. And the key for me, which I teach all the fellows, is stay right up against the cartilage. It's like a Bankart repair. Yeah. People are so worried that they end up getting away from the cartilage, and that's when you get into trouble with, even with anchors, you'll see a fracture if they're too anterior and there's a stress riser there. So the key is right up against the cartilage. You're almost always on the odd facet. It's not a weight-bearing portion of the cartilage. You can get right on there, and it just protects you, even with anchors, from having a stress riser and a worry about a fracture. So I use 2 anchors on the patella. I do a 2-limb graft. It goes to 1 limb on the femur. I find the isometric spot in the femur. I'm a big fan of using it anatomy first to find the sulcus, then putting a guide pin and checking isometry. And if I don't like it, I'm not even going to take an image at that point. I'm just going to change it. If it's getting tight in flexion, I'm going to move my fixation point distally. If it's loosening too early, I'll move it a little more proximally. So I think knowing that really helps. And then when I get the graft to function the way it should, which is staying fairly isometric from 0 till about 50 or 60 degrees and then loosening in deep flexion, then I just take an image just to confirm that I'm in the ballpark. And I think that has really helped, because if I see that I'm not perfect on the x-ray, but I know that it's working perfectly, I'm very happy. And to me, the key is knowing that it's loosening in flexion, because then I let the patient get, in fact, at the end of every case, I take a picture with the knee fully bent up and their heel against their butt to show the patients that I can get full flexion in the OR at time 0. So they can get as much range of motion as they want very quickly, which I think really has prevented a lot of stiffness.
Yeah, great.
And how are you positioning the leg when you're tensioning? We hear various degrees and figure 4. How are you positioning it to optimize?
Generally someplace between 30 and 45. It really depends on the patient's own anatomy and if they have alta or not. It's when the patella is engaged in the trochlea. Okay. So I bend it just enough to get the patella engaged. I think that prevents over-medializing it. If they're really high up and on the flat part, it's pretty easy, as Miho commented, to over-pull the patella medially because it's on a flat part. Once it's got bony containment, you're really kind of preventing that when you fix your MPFL.
Yeah, that's great.
And Miho put a pin in graft choice.
So,
yes.
So I use both. I use autograft and allograft. There's no literature to show that one is better than the other. It's not like an ACL with an intra-articular where we clearly know that in a young population, allograft does not work and has a much higher failure rate. We don't have that literature yet. Hopefully, with our Jupiter study, we now have over 2,100 knees in our first Jupiter 1 and 2. We closed down enrollment for that 2021, so we should have data coming. We have lots of papers coming out now, but we're going to hopefully figure out graft choice and failure and whether or not one is better than the other, but it doesn't look like we're going to see that. Okay. I think both work well. In my hands, I think everybody just needs a reason for why they do what they do. And for me, whenever I'm doing any bony correction, if I'm doing a tibial tubercle at the same time, I'm correcting their alta, I'm correcting their TTTG, I'm distalizing them if I need to. So I'm removing a lot of the anatomic risk factors, and in that case, I'll always use allograft because the pull on the patella shouldn't be very much. I'm correcting a lot of those factors. If I'm doing an isolated MPFL, I use an autograft for everybody because it just heals faster. I'm not correcting. They all have anatomic abnormalities, all of them. There's no patella dislocator that I'm ever going to fix that doesn't have some trochlea dysplasia, alta, femoral antiversion, some variety. And in those cases, I do want the graft to heal faster, and it will heal faster with autograft.
Beth, I thought it was a casual conversation that we had when I was a fellow, like 100 years ago, maybe, when we were talking about allograft versus autograft. And I thought it was you that said, these patients have really stretchy tissue. And so it doesn't really make sense to take a patient's stretchy tissue and then replace their stretched out tissue with their own stretchy tissue. And so we were kind of leaning towards allograft with that. Was that not you?
I don't think so.
I'm misquoting.
And I will
never
say
said
I
that.
actually have a philosophy on that because people have said that to me, especially a lot of these patients have very high Baton index scores, and so but Scott Rodeo has done tremendous work with this, and all of these ligaments undergo religamentization, and they auto-populate the patient's own tissue. So whether I put allograft in you or autograft in you, it's going to be your tissue in 5 years.
Yeah.
So that to me, again, I think it's going to be your tissue at some point. And if I put a semi-T in your knee, even if you have a Baton index score of 9 out of 9, that's going to be way stronger than any ligament you had before.
Well, I've been misquoting you for a long time. Sorry about that.
Awesome. So you mentioned osteotomy. So we do want to talk about associated procedures you can do with an MPFL. But before we get to osteotomy, we want to talk about soft tissue. So Miho, is there a role for adding a lateral soft tissue procedure like a lateral lengthening? And if so, what are your indications to do that, and how do you do it?
Yeah. So I think there is a role. I think it's very limited. So if you look at these studies comparing MPFL with and without lateral release, really the same, if not a little bit worse with the release. The only time for me that I do anything laterally is if the patella is so far out that you can't even reduce it to the trochlea, which I learned from Beth. That rarely happens in an isolated MPFL, and in my experience, they usually need something more. So in an isolated MPFL, I've never had to do that. With TTOs, when we're trying to get them over, they may need it. In those cases, I actually still do a limited release. I don't do a lateral lengthening. One, I don't like the extra incision, but two, I really like to be able to see what I'm releasing. So I've seen a lot of medial instability where it either goes into the vastus and their quad shuts down, or it goes into the lateral patellofemoral ligament, and I have to end up fixing that. And so I like to see exactly where I'm releasing, which is the articular surface of the patella. And I feel like with the lengthening, even though you're providing that check rein, I still can't see that as well. I think either are okay. The literature shows that, either way, you're not having medial instability if you're being careful or if you're doing a lengthening. But that's kind of my thought process on it.
Absolutely.
That's also a callback to my physical therapy days where it was lateral release, evaluate, and treat. That was another popular.
Very popular. One of the that was the single most billed code in the 1970s and 80s.
Wow.
Was lateral release. Yes, it's where lateral release got a bad name. What I say is, and I'm not a releaser. I'm a lengthener, just as where we sit on the spectrum. But I will say, I always say for my patients, anyone who's having a patellar stabilization on the consent form, it says possible lateral lengthening, lateral release, because it's part of a balancing operation. Again, not everybody fits into one bucket. I have most of my dislocators are what I call loose dislocators, but I do have tight dislocators where they have the combined malalignment with instability. You get them on the table, you can't get them out. And an examiner anesthesia is different for an ACL. You have to be able to pivot someone to do their ACL. That's just mandatory. If I can't pivot them on the table, I shouldn't be there. We're not doing their ACL. Very different EUA for a patient with instability. You can't always get them out because my thumb doesn't have the pressure that they will have with rotation, planting, and turning. Their body weight will be able to get their patella out. And those tight dislocators, they will have a higher risk of osteochondral injury, higher risk of cartilage damage. And so in those patients, I do find that lateral lengthening really does help. Adam Yankee has this term, you have to line up the putt before you fix the MPFL. So meaning the patella has to be sitting where it's supposed to sit before you put an MPFL in. The MPFL is not a pulling ligament. It's not going to drag something to where you need it. And it's not even going to hold it there if there's a ton of vector force pulling it out. It's meant as a check rein, and you have to get your patella in the right spot. So for tight dislocators, I probably end up doing lateral lengthenings a fair amount of the time. But overall, in the general scheme of things, it's probably less than 20% of my patients with instability need anything done laterally.
Yeah, I think that's a great overview. That's helpful.
Absolutely.
So next up, we're going to talk about the addition of osteotomy. So we know you both speak about osteotomies a great deal, and we're not going to go deep dive in the osteotomies, but a little bit about the indications. So Miho, what is your indication for a TTO in the setting of an MPFL reconstruction?
Yeah. So there's different things that you can do with the TTO, right? This is why it's such a powerful tool in instability, because you can medialize, you can anteriorize, you can distalize. I think the most common thing, at least in my practice, is medialization. I still do that, and we use the cutoff of approximately 20 on CT. And I think once you see past that, you're starting to think about, is there some sort of alignment issue? Now, the TTTG is not just about the position of the tubercle. It's really a representative number that looks at a little bit of version, a little bit of valgus, and essentially that distance there is going to tell you that there's some sort of alignment issue. We actually have a poster here redoing the numbers on MRI, and we also looked at sex and height with this. And so what we found was that on MRI, if you looked at the symptomatic versus normal patients, the cutoff was 20 for tall men only.
Okay.
But for someone my height, it was actually 13. And a tall female, 16. So I think we really need to start thinking about our cutoffs and how we... And I think that's also why some in the literature, the TTTG is just getting washed out, and it's not showing as that relevant. But I think we need to be more size specific. Anyways, going back to that. So in general, about a little, over 20, I'm thinking about medialization. A CDI greater than 1.4, I'm thinking about distalization, although I hate to do that, so I try not to do it. And then, of course, if there's any sort of chondral lesion laterally or inferiorly that needs to be offloaded, then I'm thinking about anteriorizing there.
Yeah.
So I think that's a great summary. For me, always it comes down to what are we treating? And I always try to go with these two big circles that overlap in the middle. On one side is pure instability, and rarely, if ever, do you need a TTO for pure instability. On the other side of the circle is a big circle that says malalignment with arthritis, and those are those lateral malaligners, and you can have them with no instability. You'll see them. They've never dislocated in their life, but it's like a bus with all the kids moved onto one side, like a school bus. They've been riding on the outside of their patella for 25 years or 30, whatever. I just saw a 22-year-old who has full thickness bipolar OA on the lateral side because that's just where she's lived every day of her life, and she's never dislocated. And then you have the crossover, the people who have both, the people who are laterally malaligned, and they've also dislocated a few times. Because the common theme between both of those circles is trochlear dysplasia. Both groups have it. So I think the critical part is, what am I doing the TTO for?
Right.
And if I know that it's pure instability, I am rarely going to be doing it. In addition, we're doing this Jupiter grant study, so I don't do it at all right now. I'm doing just MPFLs for those patients because we do want to try to get an individualized instability severity index score, or ISIS score, just like we have for the shoulder. We want to find that for the patella. But I think in general, when I'm teaching my fellows, I'm trying to say what I want you looking for is that overlap group, the patients who have malalignment and instability. Those patients need an MPFL for their instability, and they need a TTO for their malalignment. That's the patient that gets the MPFL TTO. But they're not getting the TTO for their instability. They're getting it for their malalignment, because oftentimes we'll see patients who have had their MPFL done when they were in high school and dislocated 2 or 3 times. Now they're in college, they're getting effusions, they've never dislocated since. You get an MRI, they're stable, but they have breakdown of their cartilage. And that's just because we just didn't see it coming.
Yeah.
So I think that's a really important factor for me, is knowing what I'm treating.
Yeah.
Now, a point I always like to ask people when we talk about TTOs on any of our episodes is distalization. And Miho, you said you hate having to do that, but sometimes, I'll have people with CDIs of 1.5, even higher. And so you have to bring them down a little bit. And the question I always ask myself is, how distal do I bring them? Because I don't want to give them BAHA, but I don't want to do this and then not distalize them enough. So what are you aiming for? A question for both of you in terms of CDI at the time of surgery.
Yeah. So for me, I'm bringing them to 1.2, 1.1. I'm definitely not bringing them to 1. We had this conversation this morning. I don't know. How about you, Beth?
100%. I only bring them to 1.2. I love distalization for instability. There are lots of people who use distalization for arthrosis, and very rarely do I think that's needed, because the whole concept is the biomechanics, and it's the pressures. And when you distalize somebody, no matter whether they're alta to begin with, you are shifting the load from the inferior pole up. So you are definitely, the inferior pole sees less contact, but overall your patellofemoral contact pressures go up when you distalize. So to me, an isolated distalization doesn't ever occur. I'm always going to be distalizing and anteriorizing at the same time to offset those increased contact forces. So for instability, I do think it's really important. And if you look at some of the literature, ALTA is bearing out as a more important factor than TTTG in most of the new research that we're seeing. I think it's because, and there's also this thing that David Deets loves to talk about, which I agree with, which is functional ALTA. Somebody who isn't ALTA on their x-rays, but they have so much hyperextension that they function in ALTA. And so I think it's a really important thing that we have to think about. It's a very necessary tool in your toolbox, and I agree with Miho. I don't sleep as well with my distalizations. The only fractures I've ever had in over almost 1,000 cases. I mean, and the distalizations are the ones they occur in. They don't occur in the routine Fulkerson osteotomies. You just never see them. So you have to think about how you do it. You have to be really careful. I've added a compression plate to my distalizations in the last 2 years purely to avoid that because it gets quicker healing. So I've added a compression plate.
I think the point here, because there's a lot of things that we're taking into consideration, but thinking about things globally in terms of how things are additive, right? And so not just chasing one thing. And if you look at some of these studies, that are trying to look at the multiple risk factors, we actually looked at MPFL length changes, as did you, right? You did the cadaveric study, and we did a clinical study. And basically, we know that for MPFL reconstruction, you want to have minimal length changes throughout range of motion. And if you add an increased TTTG to that or increased patella alta, then you're not going to be able to get that sort of isometry or isometric function. And so in one of our studies, we showed that with every additional risk factor, those length changes increased. And it doesn't matter what that risk factor is. It could be dysplasia, alta, TTTG, but it's really thinking globally about how many of these, and which is what you're saying, the malaligned patients. But it's important because we're not addressing the malalignment just because they're going to get arthritis. We need to do that in order to have a well-functioning MPFL at the same time.
Yeah.
And I would just back that up and I would say 100%. It's the combination of risk factors. This is a multifactorial problem. We're not going to hang our hat on one number like 20 to solve this. It's a multifactorial problem that is a multifactorial answer. So you can have a patient that has a TTTG of 15 that needs a tibial tubercle osteotomy if they also have alta of 1.25. And I'm making up numbers, but I'm saying it's going to be a combination of variables. That's why the ISIS is so important.
Right.
Because we're going to see that if you have a TTTG of 15, but you don't have a Baton index and your alta is normal, then you're going to be fine with your or TTTG of 22 will be fine as long as they don't have the other risk factors. Whereas a TTTG of 15 or 14 even, which is in the normal range, won't be okay if they have the combination of alta or ligamentous laxity. It's going to be a combination of variables that will eventually predict when we should be doing this surgery.
And this is why people hate treating patellar instability. That pretty much sums
We
it up.
haven't even talked about trochleoplasty.
Yeah,
But what I wanted to sort of like quickly pause and sort of point out, which I think we find really exciting, is we're talking to Brian Cole a few days ago about over the years how he started to look at like osteochondral problems and we have say X failure rate. How do we tick away at all the little things to sort of make this whole sort of problem better? Everything from like imaging to graft prep to how do you put it in and what and you guys are really doing the same thing. You're really tackling a very big problem that we haven't always handled well. And really saying, okay, how can we image better? How do we break down the imaging by sex, by height, all the way to all the little detail of, so it's more of just, it's not a question. It's really just sort of saying, we're very appreciative.
And I think we're trying to get more patient specific. To your point,
That's
right?
exactly
It's
it.
not one size fits all. And so it is going to be something where we try to cater to each patient what they need.
Yeah.
And Brian Cole was talking about machine-based learning and using AI assistants to kind of guide this. He's like, the future eventually we will be able to plug in male, gender, BMI of this the size lesion, it's medial femoral condyle, their alignment is this, what should I do? And it'll spit out, MACI or it'll spit out OCA. It would be wonderful if one day, based on all the studies you guys are doing, to be able to plug in female, TTTG of this, all this alignment, hyperlaxity, and then they tell us what they need,
That is the beauty of
data.
AI, and that is where we're going. And we actually have this concept of supervised versus unsupervised learning in groups so that we can really start to figure out, because there's too many variables.
There is so many. Yeah.
So many variables. So, well, you brought up trochleoplasty, so you were going to ask that question.
Okay.
I don't want to touch that.
Briefly.
Briefly.
Obviously, you already indicated that it's not a common procedure. Not that many people are even doing it in the country. It's very specific sort of sites that are addressing it. So, where does that fall for you both? But Miho, we'll start with you.
Yeah, well, I think I alluded to, the TTTG being representative of an alignment issue earlier. And a lot of that you can correct with TTO. But there are some patients who have, what we think of as the jumping J sign, what I usually see on the dynamic CT, but you can see it on exam as well. And so a lot of these patients who have a really high TTTG, something around 30 or higher than that, you have to start thinking about, is there something else besides the TTO that they might need? Because you can only correct 10, maybe 15 tops, depending on how large the patient is. And so with those patients, after you correct the TTTG and you bring it down and they're still having a jumping J sign, the really dysplastic patients who have that sort of de jour D where it's a huge cliff and the trochlea is actually way medial, that's actually increasing the TTTG distance. So it's not a lateralized tubercle, it's a medialized groove. And so in those cases, if you bring the tubercle over and it's still high, then you can bring the groove over. And so those are the times that I do a trochleoplasty. Very, very uncommon, but it does help.
Yes. Beth, anything?
I agree. I think it's a very, very uncommonly used tool in my toolbox.
Yeah.
I think it's incredibly important to be able to do it if you are a very high volume patellofemoral surgeon. I think for the general surgeon, orthopedic sports trained surgeon who's doing 15 or maybe even just 15, 20 patellar instability cases per year, that's probably not the best indication for a trochleoplasty because you're not seeing enough of it to understand where it really fits in. So in a patient that Miho was talking about that has a medialized groove, when I see a TTTG that's over 25, my brain starts to think about femoral anteversion in addition because the only way to get so much distance is not, you don't have enough external tibial torsion to get there. So you have to start thinking that the track is rotated medially. It can be rotated medially because of dysplasia, but 97% of our patients who dislocate have dysplasia, and I'm telling you 97% do not need trochleoplasties.
Yes.
I think it is less than 1% of our patellar instability patients that need trochleoplasties. So oftentimes a derotational distal femoral osteotomy will help us correct that TTTG as Miho was talking about. And so even with trochlea dysplasia, you'll be fine not doing a trochleoplasty. For me, it's somebody who's failed a well-done TTO and MPFL, who does not have rotational deformity, who has a de jour D with a large lateral bump. And oftentimes it's not because they're dislocating. In my practice, the ones I've done have ones that I've only done one primary. The others have been revisions of my own surgery. And it's not because they've dislocated, it's because they really don't like that large J sign that they still have. The dislocations go away. It's because of the patient's own satisfaction with how their knee is tracking and the feel of the pull. And so that to me is really indicative that I'm not doing it for instability. I think we've got that trick down. I think we can control instability very well without a trochleoplasty.
Yeah. Great point.
Absolutely. Miak Orthopedics is leading a shift in the treatment of anterior cruciate ligament tears, from reconstruction to restoration with the Bear implant. Bridge-enhanced ACL restoration facilitates healing of the torn ACL. Unlike reconstruction, the Bear implant does not require a second surgical wound site to remove a healthy tendon from another part of the leg or the use of a donor tendon.
The Bear implant acts as a bridge between the two ends of a torn ACL. The surgeon injects a small amount of the patient's own blood into the implant and inserts it in between the torn ends of the ACL in a minimally invasive procedure. The combination of the Bear implant and the patient's blood enables the body to heal the torn ends of the ACL back together while maintaining the ACL's original attachments to the femur and tibia. The Bear implant is resorbed by the body as the ACL heals.
To learn more about the Bear implant, including clinical study results and instructions for use, visit www.bearimplant.com. So we want to wrap up today talking about rehab, so what your post-op protocol looks like. So Beth, let's start with you in terms of bracing, any range of motion restrictions, weight bearing, kind of how are you counseling these patients for post-op?
I brace everybody, MPFLs and TTOs. I brace them straight. I lock them straight for 6 weeks. They take the brace off several times a day and do range of motion. I don't put limits on their range of motion. I put benchmarks. Okay. So for me, it's they have to be at 60 by 2 weeks. They have to be at an easy 90 by 6 weeks. And then after that, we let them go full. And in fact, they can get to full motion well before that because, as I said, my MPFLs can bend day one all the way. It's more just making sure they don't get stiff, so we give them things to aim for, but we tell them that they can go full.
Yeah, I like that.
Yeah. I do a brace locked and extension only for ambulation, and I leave the brace unlocked, and I have them start a home exercise program on day 3. So usually by the time they come in and see me, they can get to 90. I like them to have full by 6 weeks. I have crutches maybe 1 to 2 weeks, but it's really for comfort, and try to get them out of the brace somewhere between 4 and 6 weeks. That's for an MPFL. Obviously, for the TTO, range of motion stuff is the same, but crutches for 6 weeks, and then progressing from there.
Yeah,
absolutely.
And then as far as returning to sport, what do you sort of counsel them when you're talking about this surgery? If it's just MPFL reconstruction, don't worry about the TTO.
Yeah, so you mean in terms of timing?
Yeah.
Yeah, so usually I say somewhere between 6 and 8 months is when they, or when they pass their return to sport
Sure,
assessment.
yes.
And I say, I
Criteria.
don't guarantee that you're going to be able to pass at 6 months. I think most of my patients probably fall right around 7 or so if we're being really strict with the 95% LSIs and things like that.
I was much closer to that number. I was almost exactly that number until about 2 years ago. And then I started to examine why we do return to sport. And really, it came from the world of ACL. In ACL, in my practice, it's because the risk of having another ACL is so high. Our risks of MPFL are much lower. So returning them to sport earlier is now my criteria. And also, a lot of these patients don't start out with normal quads. So to make them get a normal quad will take you forever and take them forever, and they will both be really frustrated.
Yeah.
So we're hitting around 5 months. Most of my MPFLs are back to full sport by around 5 months. They're starting the process.
Yeah.
Absolutely. Now, for the return to sport testing, I always want to ask this because I feel like there's so much data on ACL. So when I do return to sport testing for an athlete with an MPFL, I use the ACL return to play, which could be wrong. But are you using similar biomechanical assessments?
Yeah, absolutely.
Okay.
We use the same because it's the same forces. It's the valgus, it's the rotation, it's the cutting, pivoting. Usually the same types of sports, and so we use the exact same one. Yeah.
Good to know.
Christian Latterman actually just got funded from AOSSM yesterday to start to run an MPFL specific
I
return to
saw
sport
that.
protocol. So
Wow,
it'll be very
yeah.
interesting
Yeah.
to see what that turns up.
Yeah.
That's great.
I saw that. That is really exciting. Yeah, I know there's so much work to be done there.
I was just
but
going to say, so much to
yeah.
learn. Yeah.
Yeah.
Awesome. Well, thank you so much for joining us today. I hope this was a warm up for your session later.
It's really fun. Thank you
This
so
was
much for
really
having
great.
us.
And we appreciate you
Yeah.
taking the time. We know you both are very busy.
Yeah, no, we're so impressed by all you do, and thank you for all your hard work and
Yeah.
helping our understanding of this problem.
Absolutely.
Thank you so much.
Thank you.
Thank you.
guys.
Thank you for listening to this episode of the Sports Docs podcast. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love hearing from you.